Welcome to Maternal Health, a KET Forum. I'm Renee Shaw. Thank you for joining us. In 1925, Mary Breckinridge launched the Frontier Nursing Service, a pioneering venture which trained and sent nurse midwives on horseback across the mountains of eastern Kentucky to provide care for pregnant women and their families. This story is the subject of a recently released KET documentary, Angels on Horseback, Midwives in the Mountains, which is now available on our website at ket.org. We certainly hope you'll watch. Today, we're going to examine the state of maternal health and childbirth options in Kentucky nearly 100 years after Mary Breckinridge began her visionary project. Joining us in our Lexington studio is Mary Catherine DeLoder, a parent advocate with the Kentucky Birth Coalition, Susan Stone, president of the Frontier Nursing University, and Dr. Coy Flowers, an OBGYN with UK Healthcare Women's Health in Georgetown. And we have pre-recorded interviews with other guests that we'll share throughout the program. Before we begin our conversation, we want to show a clip from the documentary which provides us with a brief overview of the Frontier Nursing Service and its contribution to the field.
In 1925, nurse midwives from across the globe began traveling to Leslie County, Kentucky, to demonstrate the possibilities of rural health care in America. Led by Mary Breckinridge, these spirited women delivered unprecedented care to the families living in remote regions of Appalachia. Their efforts reduced the maternal and infant mortality rates to be among the lowest in the nation and improved the overall welfare of these mountain communities for generations to come.
So we want to start by putting a spotlight on the profession of midwifery, exactly what it is. Susan Stone, explain to us, what is a midwife?
Okay, a midwife is someone who is educated to care for women. And so actually the title midwife means with women. And certain types of midwives, both certified nurse midwives and certified midwives, care for women throughout their lifespan. So primarily from the time that they start to think about birth control and that kind of thing through menopause. And of course, there is a focus on maternity care during that time.
You just mentioned two types, and you said it pretty fast. I'm going to have you say it again. There are two types, right?
I'm sorry, there are actually three. Okay. There are certified nurse midwives who are nurses with a master's degree in midwifery, sometimes a doctoral degree. And then there are also midwives who have that same education. There's 5 programs in the country now where if you're educated maybe as a physician's assistant, you can go on and become a midwife. So it's the same type of education as a nurse midwife. And then there's certified professional midwives that are educated primarily for maternity care. They don't have the full scope of gynecology care and that kind of thing. And they focus on maternity care and primarily work in the home. They primarily do home births and some birth center births.
So tell us about how the U.S. stacks up in the use of midwifery compared to other countries.
Well, as you know, is that our maternity care outcomes are not as good as any other industrialized country. And when you look at the number of obstetricians located in those countries compared to ours, it's not that different. We have almost the same number of obstetricians, but midwives, they have tremendously more midwives. So, for example, in the United States, it's, I think, 4 per 1,000 births. And then in England, for example, it's 46 per 1,000 births. And that you can see, Netherlands at 78. So we have obstetricians, and then we don't have the midwives. So overall, we're just lacking maternity care altogether. And I think that that results in the outcomes that we're seeing.
And we'll talk more about those outcomes as we go throughout our program. Mary Catherine, thank you for being with us. Tell us about your experience with midwives and why you become so passionate about this issue.
Sure. Well, before my first child was born, a little over 10 years ago, I learned about the midwifery model of care and decided that was something that really appealed to me. So when I became pregnant with my first child, I first began seeing a certified nurse midwife who worked in a hospital setting, and then I also learned about home birth. And I wanted to pursue that and explore it, and I found out that it was really challenging in Kentucky at that time to find a provider to attend a home birth. It wasn't just something you could go on the internet and look up like you could maybe an OBGYN. And I thought that that was kind of crazy, that you had to really work so hard to find a provider. I did end up finding a certified professional midwife who served my area, and worked with her with all my children. I have 4 children, and 3 of the 4 ended up being born at home. So after that experience, I got involved with what is now the Kentucky Birth Coalition and wanted to make it easier for other families who are seeking that type of care to be able to find a qualified provider. And so Kentucky Birth Coalition was kind of the most recent in a long line of organizations over several decades that have worked to increase access to that type of midwifery care. And in 2019, we were able to get a law passed to license certified professional midwives in Kentucky, making them easier for families to find when they're seeking that care.
And I was just going to ask you about that legislation from a couple of years ago. This applies to certified professional midwives only, correct?
Correct. The type of midwives that are educated, for example, at Frontier, the nurse midwives, they are licensed and always have been in Kentucky as advanced practice nurses. But most of them in Kentucky practice in the hospital setting. There are about 7 currently who attend home births. They can do that if they so choose to, but there's a lot of different reasons why they might choose to work in a hospital versus home birth. Right. So a lot of the rest of the home births are left to other types of midwives in Kentucky. And so those types of midwives hadn't been credentialed by the state. They actually were in the 1950s to the 1970s. You had to get a permit from the state back then. And in the 70s, they stopped issuing permits except for to the nurse midwives. And so all the other types of midwives were sort of left with no options to legally practice, and it essentially pushed them underground. So different groups of families have been working really since the 70s until 2019 to change that.
Isn't that something? It took that long, right? Dr. Coy Flowers, thank you for being here with us.
Thank you.
Can you tell us about the relationship between OBGYNs and midwives, and how has it evolved essentially too?
Absolutely. I'm recently new to Kentucky over the last 2 years, and in the last 4 to 5 years in Kentucky, there's been a revolution in the relationship between OBGYNs and midwives. I think because, as I think many of us know, that 50% of the counties in Kentucky don't have an obstetrical provider or a place for patients to deliver. And so it's sort of become an all hands on deck philosophy, if you will, that there are not enough OBGYNs to go around. We need colleagues, midwives particularly, both CNMs and CPMs, in order to be able to provide the care to patients that we need to. And so it's essential for all of us to work in a collaborative way in order for us to provide the best care possible.
And so how does it enhance what you do?
I work in a small practice in Georgetown, Kentucky. There's 2 OBGYNs and 1 midwife. The 3 of us communicate every single day with each other and rely on each other, number 1, for sleep. If I didn't have a nurse midwife, I wouldn't be able to actually take my pager off on certain days. Sure. And so it's essential for us to be able to care for patients. I have a lot of responsibilities as an OBGYN that are outside of the normal birth plan, the birth care process. But my midwife loves that aspect of it, loves to sit down and talk to patients about every aspect of their obstetrical care. And that's something that takes the burden off of me so I can focus on things that are gynecological surgery, hysterectomies, bladder slings, things like that. And so working as a team, knowing what we know best, our strengths and our weaknesses, is the best way possible to take care of patients in Kentucky.
And hopefully leads to better outcomes for mom and babies.
Absolutely. And I think that you're going to hear tonight, and already have, that the data proves that. That working as a team in all those different aspects gives better care to patients in the long run.
Yeah. We're going to talk more about that, as you just said, in just a little bit. But we'd like to go to another clip from Angels on Horseback, where we learn more about the history and evolution of childbirth practices in the state and nation.
In 1900, 50% of women gave birth at home with a midwife. By 1930, only 15% of women are attended by a midwife. And early 20th century, there's this backlash against midwives, painting them as a threat to society, and that if you have the means, you need to have a trained physician. You have to have the best of the best there, ready to handle any situation that arises, and a midwife isn't prepared to do that. You know, ignoring the fact that midwives had delivered babies for hundreds of years.
So this is a point, Susan Stone, I want you to pick up on, you know, viewed as a threat, right? And so let's talk about seeing childbirth, this shift as a natural part of life to seeing as a condition that required some medical interventions and management. Talk to us about that.
Well, there were so many factors that went into it, but we had a lot of immigrant midwives who came to this country with their families and with their communities, and that provided excellent care to women. And if possibly we could have had collaborative care at that time, we might have been in a much better place. But there was a movement by physicians and by organized medicine and by the government to more professionalize maternity care. There was one factor for women was they wanted pain relief. So they started to have pain relief options for women, which were not all that great because they might be ether or being put to sleep for your baby. And so anyways, it became a movement mostly by the medical profession to get rid of midwives and to bring birth into the hospital. There was a lot of complications that went along with that, a lot of infections before they really realized about infection control, about bringing people together and how that can, as we've seen with COVID, cause different infections and different things. But it was very dramatic, as you quoted the figures. It was a very dramatic change to make sure that these midwives could not practice. Now, in some states, like way down in Mississippi, it went on for a lot longer because there was nobody that wanted to go do those births, right? But in the urban areas, it became a very medicalized procedure which is not a medicalized, but it's a normal part of our lives. And though it can go very wrong, it can go very right a lot of times by leaving it alone and just watching to make sure nothing bad happens.
Right. So the wisdom, I guess, was if you were in a clinical hospital setting, surely you'd be better off, mom and baby, than if you just did it at home.
Right.
Right. And then that's just not true. That's
not true because obviously, well, I don't know if it's obvious or not, but when you put a woman in a hospital, if there's not enough people around her to take care of her, if you're at home with a midwife and there's a midwife with you one-on-one, or if you're in a hospital with a midwife one-on-one, then somebody's watching what's going on with you. If you put a mother, 9 mothers in a hospital with one nurse to call one doctor, things can go wrong.
Right.
So the data shows us dramatically how birth moved into the hospital.
Dr. Flowers, I want to come to you now and ask you about, because we kind of left it there before we just saw that clip about how your profession has evolved to embrace midwifery, not looking at it as a threat, but as a collaborative team effort, as you just mentioned, and how it can really lead to better outcomes for mom and baby. And it really is not a threat to the profession.
I would agree. And things over the last 20, 30, 40 years have changed dramatically. I was a forceps baby. My mother was taken into a delivery room. She was given a twilight sleep, and I was pulled out with forceps.
Right.
So I remember my first pictures having the bruise on my face from the forceps. And so we don't do that anymore. 20 years ago, when I first started this profession, I think patients would bring birth plans into my office, and there were a lot of things that we didn't do routinely. Things have changed over the time. Dad wants to cut the cord. Mom wants skin to skin. Mom wants to breastfeed immediately. Doesn't want an episiotomy every time that she's admitted for a birth. There are so many things that now that we used to do routinely over the last 20, 30 years that we don't do anymore. And so we're incorporating a lot of those aspects of care to allow women the autonomy to choose exactly what their birth is going to look like.
Yeah. And what are the common choices that women are making?
The ones I just mentioned. They want the philosophy of if things are going well, let it be.
Right.
Just let it be.
Just let the natural
let it happen naturally.
Take its place. Yeah. How do you balance mitigating the risk of enhancing the birth experience and let nature take its place?
That's a good question. In the birthing process, if you let it happen naturally, the risks sort of minimize themselves over time. And I think too much intervention, which we've seen in the past, has caused more problems than it was designed to preclude.
Right. So for higher risk pregnancies, is there more of a concern there or different approach and method?
Absolutely. There are a certain percentage of patients which need to have a higher level of care, and we all recognize that. And that's why I think it's super important for us to be able to have that communication of all levels of care. Not that one is higher than the other, it's just a different type of aspect of what that particular provider can provide. And so there definitely is, there are patients that need to be seen at a tertiary center, at a quaternary center. C-section rates, for example. The introduction of C-section has been proven in study after study in order to, it has been able to shown to help lives, and be able to save lives and save babies. But our C-section rate has gotten way too high over time.
Yeah, what we know that studies have shown that using midwives over obstetricians has resulted in a 30% decrease in risk of cesarean delivery in low-risk patients, 40% decrease in risk of cesarean delivery in low-risk multiparous patients. I'm not sure what those means. Nulliparous and multiparous. I'm probably not saying that correctly, but what's the difference there?
Multiparity is somebody who's had babies before, and nulliparity is somebody who hasn't had a baby before.
So I want to go to you, Mary Catherine DeLoder, and ask you, you said earlier when we started our conversation that 3 of your 4 children were at home. They were home births. So tell us about the home birth movement and where you see it going, and how it's been able to sustain and grow, perhaps, in popularity.
Sure. Well, home birth isn't for everybody. Maybe it's not because they don't want to choose that for themselves. Maybe someone wants the pain medication that's offered in the hospital, or maybe they're not medically a good candidate for it. So that's important to understand. But people are often looking for something different than what's being offered in the hospital. And they are aware that sometimes interventions, which can be life-saving, but sometimes they are used unnecessarily, as Dr. Flowers referenced, in the hospital, and so families and mothers want to avoid that, and so oftentimes they will choose home birth for those reasons, and people really choose home birth for a whole myriad of reasons. It is certainly not as popular as it was once many years ago, but it is more popular than it was just a couple of decades ago, and we think that if someone wants to choose that option, we want them to have the best care possible in that setting.
And for some people who are worried that it may be too dangerous, may not be for them, or they're concerned about risks that may or may not be present, what do you do to console them?
Well, like we see in some other countries that utilize midwifery quite a lot, is integrating midwifery into the greater maternity care system is what makes it safer. So Kentucky has come a long way in doing that, especially, as I mentioned, in 2019, licensing the certified professional midwives. That sort of brought them out of being an underground profession, gives them access to things that are very important to help make the process safe, such as specific medications that might be needed, for example, to treat a postpartum hemorrhage, to be able to access lab tests that their patients will need, and also gives them a greater ability to interface with other providers, such as obstetricians and hospitals, so that they can have that professional relationship and be able to move their patients to a higher level care if needed. So it's also important to remember what I mentioned is that home birth medically may not be for everyone. The first time someone meets with a midwife, the first thing they're going to do is talk about, if they're choosing a home birth, that is, are they a good candidate for home birth, or do they have a specific condition? Perhaps they have insulin-dependent diabetes, or maybe they've developed preeclampsia. So you might start off your pregnancy being low risk, but it might become high risk at some point. So the midwife is going to keep track of that and make sure that it is safe for you to be at home, and if it's not, they're there to watch and to make sure you're in the safest place that you need to be.
Yeah, real quickly, you're also working on legislation about home births. Can you tell us about what that is, and if that would come up in the 2022 session?
Well, currently we're working on legislation for a different type of out-of-hospital birth, which would be at freestanding birth centers. We could have birth centers currently in Kentucky, but we have something called the Certificate of Need for health facilities that they have to apply for through the government and get approved for. So if you wanted to open a hospital, for example, that's a process you would go through, but also smaller facilities like a freestanding birth center, which would be a place where you go just to have a baby. It wouldn't have all the other things that a hospital has, and it would be a place where you wouldn't utilize pain medication. It would be basically somewhere to go to have a natural birth, so to speak. And so getting rid of the barrier of having to apply for the Certificate of Need would make it much easier for those to open in Kentucky. So legislation we've been working on for the past few years would be to eliminate that barrier to make it easier for folks to open a freestanding birth center in Kentucky, because we currently have none of those in our state.
And I said home birth, but I should have said birthing center, so pardon the slip of the tongue. So now we want to introduce you to another concept in modern childbirth, which is actually a very old concept, and that's a doula. I had the opportunity to speak with doula Renee Basham of Hope's Embrace. Renee Basham, it's a pleasure to have you with us.
Hi, thanks for having me.
So talk to us about what a doula is. Can you define that and maybe its origins?
So doula actually comes from the Greek word that means woman who serves. It's always been kind of this role that women would come alongside other women and help them throughout their pregnancy, labor, and birth, and even the postpartum period. And it wasn't until probably about the 60s that the term kind of got coined in the United States as like a companion who would come alongside you and fill that role.
It seems, though, that it's really become more popular in the last 10, 15, 20 years. Is that true, do you think?
Yes. Within the last couple of decades, we've gotten some research out that says, the presence of a doula, that constant companion throughout your labor, can reduce your risks of interventions and reduce your risk of cesarean, and then increase your success rate in breastfeeding.
Right. Why did you want to become a doula?
I had a difficult birth. My very first one, it was long, and there was nobody there except for my husband, and he got tired because, they just don't have the same hormones that we do throughout the laboring process. Right. And I had postpartum depression with him, and it just would have been nice to have somebody there to kind of help fill that role. And that's a very good point about your own experience, kind of channeling what you do. And so what is it that women gain from that they may think it sounds only for a certain type of person, but it is becoming more conventional? What is it that women gain from having a doula by their side? You gain a lot of support, just however that looks, whether it be informational, emotional, physical. There's somebody there that you can talk to who's kind of an in-between for your doctor, if you will. You don't always get to call and ask all the questions that you have, and so a doula is trained to know the warning signs, and she can say, hey, this is expected, this is normal, or you should probably call your doctor with this question.
So it's not to replace a doctor, but to be alongside and a companion to physicians. Do physicians look at doulas as companions? Do they see it as a complementary relationship?
It's dependent on where you are, but it is starting to really gain traction that we are a part of the birth team. And so that's nice having people understand our role and even welcome us into that space.
How does one become a doula?
There's training organizations. It's not like a national certification. It's not anything that you have to do, but it is helpful to have a lot of that background knowledge.
But no certification is required for that?
Not required, no.
But it is available?
Yes.
Yes. Are you certified?
I am.
Yes.
I'm certified as a birth and postpartum doula.
Right. So tell us about Hope's Embrace.
Hope's Embrace was founded in 2016, and we were founded to connect lower-income women to the maternity services in Kentucky. So we have people all over the state that we can connect to, whether it be for lactation support, birth support, postpartum. And we were founded out of a desire to help people know the options out there and help them find where they are in their area.
Yeah. One of the phrases I understand that you're fond of saying and that trying to eradicate is, I wish I had known. What is it most women don't know when it comes to childbirth? That
they have choices and options. Most people don't know that you have the right to accept or refuse anything that they tell you in pregnancy, in birth, during postpartum. That you can leave your care provider. My third child, I switched 2 days before she was born. So you have that option at any point to say yes or no to anything. Right.
Are you finding that more women are kind of finding their voice during that process?
A lot more women understand that they have a voice, and so that's been really helpful to watch them kind of advocate for themselves and say, no, I don't really think that we should induce just because you're going on vacation, or right. Those common reasons that aren't really reasons.
Right. What do women tell you after their birthing experience about how glad they were that you and folks like you were there?
I get a lot of gratefulness, because in some instances, working with lower income women, I have been the only person in that birthing room. So it's the woman giving birth and me. And so there's a lot of gratefulness that I'm there to remember that experience with them and share in it and help them kind of relive the cloudy moments.
Yeah. Well, thank you, Renee Basham. It's been a pleasure to meet you and speak with you. Thank you for all your great work. Dr. Flowers, I want to get your response to what you heard Renee Basham just share with us.
I think that's an incredible interview. I want to give a shout out first to my favorite doula, Jody Tucker in Georgetown, Kentucky.
Okay.
Who's an experienced labor and delivery nurse who retired and now has gone back to create a doula service for our patients.
Interesting.
And so I wish more and more individuals from all walks of life who have that interest would get involved, because it's true. It's a hand-in-hand situation where patients all the time, if in my exam room, they'll say, I had 3 questions. I can only remember 1 right now. Well, who's going to answer those other 2 questions later on? And so working hand in hand with a doula, nurse midwives, OBGYNs together is optimal.
Yeah. Well, thank you for sharing that and backing up Renee Basham, and she was an incredible interview. Let's talk about maternity deserts. So looking at the landscape of childbirth options, where are we today? Many people may be surprised to learn that approximately half of Kentucky's 120 counties, and I think you said this earlier, Dr. Flowers, are considered maternity deserts, which mean they do not have a hospital or a birthing center offering obstetric care. That sounds like a whole lot in this state that's geographically vast and has 4.3 million people.
Yeah, maternity deserts, it's a national crisis. It's happening all over rural America. Where I came from in West Virginia, patients were having to drive further and further, sometimes 2.5, 3 hours in order to get their care. And that's why a lot of things like inductions happen, because you don't want someone to deliver on the side of the road.
Right.
And so we're looking for solutions and alternatives to figure out how to get providers out into those areas. I don't think it's feasible for us to expect that 24/7 obstetrical care for delivery is in every single county in Kentucky. The question is can we get prenatal care out there to those counties, and how do we do it best as a team?
Yeah, and what's the answer?
The answer is going to be all hands on deck, like I mentioned before.
Yeah.
It's going to be OBGYNs, nurse midwives, family practitioners. When you look at the same issue we're talking about here, where nurse midwives did a huge number of deliveries back in 1900 plus, and it fell off precipitously over time. Same thing with family practitioners. When you ask those individuals, they used general practitioners, which they called them in the old days, used to do a ton of deliveries in prenatal care. They're not doing them anymore. And that's because of the liability crisis.
Yeah. So, Susan Stone, I want to come to you. The Frontier Nursing Service is now the Frontier Nursing University, which, congratulations on, no longer provides service to moms. So tell us about this transition and why you moved out of the mountains and discontinued providing services.
So that is a very long story, but the hospital, we were a critical access hospital, 25-bed hospital, and we did have a midwifery service. Over the 12 years that I worked there trying to recruit an obstetrician, so when you try to pay a full-time obstetrician and 2 to 3 midwives, and then you have 125 births a year, is very difficult to do and to have any consistency in care. We couldn't find family practice physicians, and finally, it's just very difficult to run a hospital by yourself anymore. They need to be in a system. I mean, we're talking about electronic medical records and all kinds of things. But I think even in that little hospital today, a model where you had a family practice doc and a couple of midwives, and that family practice doc could be doing other things like primary care and let the midwives attend the normal births. And then in the back here, you have a screen that attaches you to your obstetrician or your maternal fetal medicine provider, and good transport and that kind of thing. It can be done, but we don't have enough midwives to recruit to go to those rural areas. So that is one of the things we do at Frontier Nursing University. We recruit those nurses from those areas, educate them in those areas, and they're more likely to stay in those areas. And that is one strategy. But there are ideas out there, but we have to have the people in place to make it happen. And that's going to take funding, recruitment, to family practice. I think family practice are like, it's just gotten too complicated and too risky.
Yeah, you mentioned the litigation there. Yeah.
What you're seeing, I want to emphasize everything you just said. You're seeing now a regionalization of care in order to best care for these patients. And telehealth is a big component of that. Having your academic tertiary centers, University of Louisville, University of Kentucky, and others, really getting out there in a telehealth way, but having midwives, family practitioners on the front line.
Yeah. Mary Catherine, I want to ask you, how does the Kentucky Birth Coalition think it can help reduce the amount of centers or lack of centers, maternity deserts that are in the state?
Well, I think having more options, as Dr. Flowers keeps mentioning, is all hands on deck. So the more options that we have for birth in Kentucky, the better off everyone is. So now that we have licensed, certified professional midwives as a greater option for families, that can help. Some of those folks are able to go and serve areas where there may not be a hospital. Also, by opening freestanding birth centers, hopefully in the future, that will give people additional options. So the more options we have, it is always a better thing.
Yeah, and the legislation could help move that along, right?
Certainly.
So now let's turn to talk about a topic that is not so pleasant to talk about, and that's maternal mortality. According to the Centers for Disease Control, the maternal mortality rate in our state is more than double the national average and continues to trend up. And the death rate for Black pregnant women is 3 to 4 times higher than it is for their white counterparts. 60% of those deaths are considered preventable. Before I come to our panel to discuss this issue, I want to share an interview I did with Damara Jenkins, Director of Midwifery at U of L Hospital. She serves on the state's Maternal Mortality Review Committee and is also a member of the Louisville Coalition for Black Maternal Health. Damara Jenkins, thank you for being with us for a few moments. We appreciate your time.
Well, thanks for having me.
You serve on the state's Maternal Mortality Review Committee, and our maternal mortality rates in Kentucky are higher than the nation, which is higher than most developing countries, which may be surprising for some to hear. Help us understand why we're ranked as low as we're ranked and what the committee has found so far.
One of the biggest problems that we face in Kentucky would be substance abuse. And because of the age of childbearing women and how that, runs into substance abuse issues, that is showing us like 50% of our accidental deaths related to pregnancy around the pregnancy period are directly due to overdose.
So what is the Maternal Mortality Review Committee looking to do to upend that trend?
If you look at the report that came out last year, our job in the Maternal Mortality Review Committee is to make recommendations to the state public health department for actions that can be taken to try to fix these issues. The other thing that we determined is that 3/4 of the deaths are preventable. And one of the main ways that we can prevent these deaths is through better care for women suffering from substance abuse disorders. We need to treat substance abuse disorders as a disease instead of as an ethical or moral issue.
Yeah. How long in the postpartum period is a death considered a maternal death? I mean, we've heard anywhere from 6 weeks to a year. Is there a more concrete time?
So there are two definitions. Maternal death is 42 days or 6 weeks, which is what most of us are used to thinking of as the postpartum period. However, in order to capture the full picture, we go out to 365 days or a year following birth or the death in pregnancy, and that is called maternal mortality. If we just did the 6 weeks or the 42 days, we would miss a lot of those overdoses.
We understand that Black women have 2 to 3 times higher rates of maternal mortality than non-Hispanic white women. What do we know about those disparities?
The thing that we have come to understand is that it's not being Black that is the risk factor, but it is racism. And to put it bluntly, that is what is causing higher rates of death amongst Black women. There has been over 30 years of research proving this, but we're just now starting to accept it and figure out what to do about it.
So when you say racism, is it access to care? Is it treatment by providers? Those things combined and more? What are the actual acts of racism that are manifesting in these disparities?
Yes, it's all those things and more. So racism is so pervasive in our culture that it affects how we examine folks. It affects how we assess them. It affects the type of pain management they get. It affects what's offered to them. It affects, their access to care. It affects how comfortable they are presenting for care, asking for help. It's just in everything.
So acknowledging that there is a problem is not a solution in of itself. What would you say the solutions are in creating a path forward to brighter futures for all women who are to be mothers and experience childbirth?
It's a problem that people want to run away from because we don't know what to do about it. But the first thing we do have to do is acknowledge it. And for healthcare providers, anyone that services Black folks, what they need to do is look at themselves. And you can do this by looking at your implicit bias. So assessing yourself, assessing your behaviors, and seeing if, even though you think you aren't behaving in racist patterns, by assessing your implicit biases, you can find that. So that's one way to start. The other thing is that we need to be really careful about collecting data and understanding where we're seeing the effects of racism so that we can get to the root and change things.
So you mentioned to me that you're one of 3 Black midwives in this state, and some may find that number shocking. And obviously you're very passionate about this work beyond just caring for your own patients, but transforming how we all view midwifery and elevate this craft, this profession. What is it you want to leave our viewers with about the importance of midwifery and the lasting takeaway you'd like to send?
We have so few midwives in this state, and we have so many folks that would like to provide midwifery care. And we know from looking at other countries, we know from looking at other states, that if we increase midwifery care, if we increase access to midwifery care in our state, we're going to see improvements.
Well, Damara Jenkins, much appreciated.
Thanks.
So, Susan Stone, I want to come to you and ask you where Damara kind of left off about recruiting more African-American midwives in this state. She's one of 3. Sounds woefully inadequate.
Right. And to be clear, when you look at the data, Kentucky's white women, about 17.2 is their rate, which is about normal for the country. Mm-hmm. But Black women or women of color, 40%. 40 per 100,000 for the mortality rate. It's a huge difference. So it is a very big barrier. One of the things that has been shown to be very effective is what we call race concordant care. So the person who is taking care of you looks like you, mm-hmm. knows your culture, knows who you are, and you feel more comfortable, no matter what that culture is, whether it's the Native American or, but we definitely need to increase the number of midwives of color. We're not just at Frontier, but the American College of Nurse Midwives. It's a big push for us to get to at least 35% students of color. At Frontier, we're now at 28% and trying. Mm-hmm. But it is, in order to do that, we're going to have to identify our own biases in admitting students to schools, in educating them while they're there, in taking care of them and making sure they feel inclusive. It's an inclusive environment, right. Safe, and so that then they can go out and provide that care. We're going to have to invest.
Yeah, yeah. Here. Dr. Flowers, I want to ask you, in addition to the Maternal Mortality Review Committee, there's also what's called the Kentucky Perinatal Collaborative, and it's headed by Dr. Connie White, the Department for Public Health. Tell us about that collaborative, what it's addressing.
So for short, it's called KIPQ. the Kentucky Perinatal Quality Collaborative. Every state in the country needs to have a perinatal collaborative, and we're moving in that direction. There's federal funding that's been provided for it now, as well as the maternal mortality review committees. Those two work in hand in most states in order to address the important issues that face women who are pregnant before and after their pregnancy as well. I just want to say something about your interview.
Sure.
She's right. There is racism that's pervasive throughout the healthcare system, and providers don't know what they don't know. There's a lot of biases that are ingrained in us from birth that we don't know. The more programs you have like this, the more programming we can have through KIPQ and other organizations to be able to have a provider like me, a white boy from West Virginia. When I go into a room and it's a minority individual, particularly a black woman, I say, not on my shift. But it took a while for me to get there. It didn't happen overnight. And so we need more and more programming to be able to get other providers to that stage of the game.
Right. Getting back to the maternal mortality, you know, that's not the only concern, mortality. There are other complications that can come into play. So talk about those.
Morbidity, patients who bleed too much and have to have transfusions. Patients who have hypertensive disease that end up having things like stroke and other morbidities from that. Patients who have diabetes end up having complications. The important aspect of establishing the KIPQ, the Perinatal Collaborative in Kentucky, is that now Kentucky has become an AIM state. And AIM has safety bundles that are nationally recognized. And Kentucky has chosen to become one of those states and implement the opioid use disorder model, which, as your interview rightly said, over 50% now of the deaths every single year are from women who've had overdoses. Most of those don't happen during pregnancy. They happen in around the 3 to 6 month postpartum period, and there are a lot of reasons for that. One in particular is that women lose their coverage, their insurance coverage, after about 60 days. And so there's a big push, not only in Kentucky but around the country, in order to have women have at least coverage for at least a year to maintain their sobriety, to maintain that care and that access to care.
Yeah. Dr. Stone, I want to pick up on that point. So 51.6% of accidental maternal deaths were due to drug overdose, and that's in the year 2018, the latest data available. So I want to ask you, how does opioid and substance abuse impact midwives and the work they're trying to do?
Okay, so midwives are finding themselves treating these patients, and SAMHSA, which is the federal
organization,
provides training for midwives. Midwives have now been included in medical assisted treatment so that they can prescribe things like buprenorphine or those kinds of things. And you have midwives doing group prenatal care for substance addicted women. You know, really we have to all be on deck. We have to all be a part of this.
Yeah. So now let's talk about Black Birth Justice, which is a new nonprofit in Louisville that is creating an intentional community to surround brown and black women with supportive care during the postpartum period. We went to their hub to learn more.
Hi, Keisha. How are you?
Fine, and you? How are you?
Good. Come on back.
All right.
At Black Birth Justice, we offer postpartum doula care. So that means after you have baby, we can come to your home or you can come to our hub. Postpartum is a very difficult time, and when you don't have a village around you to give you the support that you need and the resources, it can lead to things like the maternal mortality rate that we're trying to combat.
How's everything going? How's baby sleeping at night? She's sleeping very well at nighttime. She's sleeping through the night, which
I feel like most people are aware of postpartum depression, but some people aren't aware that postpartum depression is not always a big change in your mood. It could be small things that you don't even realize that you're going through. You're not connecting with baby the way you should be. We look for physical signs of swelling and inflammation, things that when you're taking care of a new baby, you just might not tap into it. And so being able to put eyes on our clients and having constant communication with them is definitely things that we are able to pick up on in that postpartum time.
This is
We supply you with essential needs that you may need after having a baby. We have pads we can give you, nursing bras, nursing supply. We offer lactation support. If you're breastfeeding baby, we go over diets, things that you should eat after having a baby to promote healthy healing and healthy bodies after giving birth.
Black Birth Justice, I actually love it. It's a community, it's for the community, for pregnant moms. My first pregnancy, I had an OBGYN. And then this second pregnancy, I had a midwife. The doula, she basically coached me, especially within this pandemic. It was like you can have only one person in the room. She basically coached me, taught me how to breathe through my contractions. She asked me how I was feeling. She asked me did I needed a break. She was just like a therapy person there on site, delivering the baby. It's very important to have resources, especially if you're feeling depressed, or you're down and out, or you're having anxiety. It's very, special to have someone to talk to, somebody in your corner.
A lot of times Black women feel like their voices aren't being heard. They have issues that they may not feel comfortable discussing with people who don't look like them, so then it's not addressed and it's not taken care of. I think that that's the biggest disparity, is just not feeling like you're in a safe space to really communicate your needs and things that are going on with you as far as your health while you're pregnant. If we can get everyone to realize that it goes beyond just 6 weeks, I think that we could definitely save a lot of lives of mothers and babies. I love mommies and I love babies, and just the overall health and knowing that I am a pillar in my community and my people can come to me and know that I can help them. I won't judge them. I won't make them feel bad for any situation that they're in. Like, I'm literally there just to help you and uplift you.
Mary Catherine DeLutter, I want to come to you because as someone who's a birth advocate who knows the importance of this type of care, during the process and after birth, how valuable are programs like this one?
Well, anyone who's had a child knows that it's not easy, especially, you get through pregnancy, you get through birth, and then you have this little person to take care of. And it really does take a village. That seems so cliche to say, but it's true. And to have a support system, not just for 6 weeks, but beyond that afterwards is so important for taking care of both babies and new moms and new families as they are learning how to live in the world and to navigate that. And so I think programs like that really take care and surround those mothers are so important. And just like we talked about, the maternal mortality, the way we calculate that, they're looking at that through 1 year. So things can happen at any point, beyond just 6 weeks that you might be seeing your care provider to follow up. So having that kind of support is really, really important.
And the emotional and mental health care is also important, right? Postpartum, dealing with depression, as we heard in that piece, and other issues, that's important to address as well.
Absolutely. Sometimes I think people have almost come to think that the word postpartum is synonymous with meaning depression, but it's not. But it is just something that depression very commonly can happen in the postpartum period. The postpartum period is everyone has one. It just means it's after you've had your baby. But because it almost has become a synonym, I think that highlights how important mental health is once you've given birth. And having that support system really helps not only to support a mom physically, but also mentally and emotionally as well.
It's important to remember that nearly every mother that dies from childbirth leaves behind a child who starts their life journey without the person who brought them into this world. I spoke with Mary Karen Stumbo, who lost her mother at birth 50 years ago, about this loss. Mary Karen Stumbo, it's a pleasure to have you with us.
Thank you for inviting me.
I'm sorry it has to be on such a topic as this, but I learned that you had lost your mother shortly after she had given birth to you by a post that you had shared on social media. And I don't think I ever knew that about you.
It's not something I share very often. People who know me obviously know the history of my family and everything that my brothers and I have gone through. But yes, it's a tough topic to discuss, for sure.
And you're coming up on a milestone of your own, and I know that milestone birthdays affect us in many ways when we think about where we come from and how we got here. And how often do you think about your mother and what you missed from your mother?
Probably every day. You know, there are things that, you know, if I'm upset, I wish that I had her to reach out to. And when my daughter is about to graduate from college, in December, you know, I think about things that she missed and that my siblings and I missed with her.
Yeah. So tell us about what you knew about your mother and the circumstances that led to her death.
Okay. She was 32 when she had me. I have 3 older siblings, all boys. She was very desperately wanting a girl, and so she finally got one, and unfortunately didn't get to really enjoy life with a little girl. But she developed a staph infection after she had me and died 6 days later.
And this was just 50 years ago, right? This isn't 1800s, turn of the century. I mean, this, we think about something as smaller, treatable as a staph infection.
Right. Antibiotics.
Antibiotics could have taken care of it.
She was very cognizant of the fact that something was wrong. You know, she'd had 3 other children and was very vocal with the nurse that she didn't feel right, that something was wrong, and they dismissed her concerns repeatedly. And I know that with my siblings that she was out of bed the same day that she had them and walking around with them, but she never got out of bed after she had me. So she knew that something was different. It just, her concerns were not passed up the chain, and, you know, by the time they were, it was too late. There was nothing they could do to save her.
Do you ever think about that, you know, this is a case in point where sometimes women just aren't listened to, even though they know what they know?
Absolutely. I mean, I think about how frustrated that she had to have been, and, you know, the changing of the hormones in her body just from giving birth and everything that she was going through. But, I mean, she absolutely knew. And, you know, that's a case where you have to explain to women, you have to be your own best advocate. When you know something's wrong, you express it. And if you're not taken seriously, you get louder, because there's nobody that can take care of you better than you can.
Well, thank you, Mary Karen.
I appreciate the opportunity to be here, and the fact that you guys are, you know, discussing this, because it is an important topic, and all these years later, you still hear the stories of, you know, women who maybe aren't listened to when they're telling you something is wrong. So it's important, and I'm glad you're doing it. Thank you.
So, Dr. Flowers, I want to come to you, because one of the big takeaways from Mary Karen Stumbo's experience is that women have to be their loudest and most vocal advocate, right?
Absolutely.
That, you know, it seemed that Mary Karen's mother was trying to communicate that something was wrong, but she just wasn't being heard.
If I could give a pearl of wisdom to any resident or intern or medical student, midwifery student that's out there, is if you listen close enough to the patient, they're telling you exactly what's wrong with them. Right. And we just have to open up our ears and our minds and follow those clues that the patient's giving us.
Yeah, they don't know the scientific or medical terms, but they know something is off with their body because they've been living with it their entire life.
They don't know the special word that those students paid $250,000 to learn.
Right.
But they're telling you in their words exactly what's wrong with them.
Yeah.
I agree.
Yeah. I want to go to you, Susan Stone. When you hear a story like Mary Karen Stumbo's, I mean, how does it resonate with you?
Well, of course, we have problems with women being heard in many situations. But I think one of the things that also goes on is the lack of maternity care. So not, you know, when you have an obstetrician who's in and out because they have 100 things on their plate and you don't have midwives in the mix, and nurses may or may not be well trained in maternity care. It depends how new they are or that kind of thing. Those kinds of things can lead to those types of errors and that lack of listening. We need better care. We need more providers.
Yeah. And COVID, I can't imagine the overlay of COVID during all of this, Dr. Flowers. I mean, that's a complicated additional aggravator, I would think.
It has been. And with the increase of just COVID amongst pregnant patients.
Right.
there has been a discombobulation amongst the healthcare system over the last 1.5 to 2 years with COVID, and we're trying to get back to more hands-on care.
Yeah. Mary Catherine DeLoder, I want to come to you for some final words about what you hope people will take away from our discussion and from the work that you're doing and the legislation you hope to soon have passed.
Particularly for physicians who might watch this or hospital administrators, I would hope that they would embrace midwifery care, bringing nurse midwives into their hospitals, into their practices alongside them, and not being fearful of that, but really embracing that all hands on deck philosophy that we've talked about, and also not being fearful of working with the community midwives, the certified professional midwives who are out in the community taking care of folks who may or may not at some point need to bring patients to them to transfer them, and to really make that a team. And for individuals and families who want to advocate for additional maternity care options in Kentucky, Kentucky Birth Coalition completely runs with volunteer and grassroots power. So we'd love to have anyone who cares about that be involved with what we're working on.
Yeah. Dr. Flowers, you gave some advice to maybe future obstetricians and others in the medical profession who are midwives. So what else would you say is a final takeaway that you hope people will really take hold tonight?
I would say a couple things. One, that OBGYNs are at the table. We're listening. We want partners. There are readily partners available. We need to have more partners available in order for us to be able to best take care of women in the state of Kentucky. And we mentioned the KIPQ. The KIPQ is having a big meeting on October 20th through 21st. You can go to kipq.org to register. It's going to focus on substance abuse issues in pregnancy.
Yeah. Good plug there. And Dr. Susan Stone, I'll give you the final word.
Oh, thank you. The most important thing is that it's going to take a whole team of different types of providers, and we have to open our arms and our doors to them. We have to have obstetricians, but obstetricians and midwives are not the same. And so if you only provide obstetrical care, you're not going to get the best care. You need midwifery care, you need the doulas, you need the Black Birth Justice, you need all of these things working together to get the best outcomes. And so that is my takeaway. We need more providers.
Yeah. As they say, teamwork makes the dream work, right?
Exactly.
Well, thank you all for being a part of this team this evening and helping us deliver some great information. Thank you at home for joining us for this very important discussion. We hope you have a better appreciation for the important role of midwifery and doulas and maternity care, and the need to provide safe, supportive birthing options for all women, no matter where they live. Please check out Angels on Horseback on our website at KET.org. From all of us here at KET, take really good care, and until next time, I'll see you real soon.